Conference will now be recorded.
Okay, so I want to welcome everybody to AnCan Active Surveillance Support Group. And as Active Surveillance Support Group, we do not talk about treatments. So if you guys are interested in any treatments, we have other support groups in AnCan that can better address those issues. So if you veer into some discussions on treatments here, we will usually pull you out and suggest another group. At this time, I'd like to recognize and thank our supporters and sponsors, and that is Bayer, Johnson & Johnson, Novartis, MyRad, Foundation Medicine, and Blue Earth. So with that, I'm going to turn it over to Eric. And Eric, you can, we have a gentleman, Jim Boland, who is first time joining us. And Eric, if you would go ahead and ask him some questions.
Hi, Jim.
Hi, Eric.
Welcome. Thanks for being
Thank
here.
You. Thank you.
Do we have your email for reminders about the meetings?
I plugged it in when I signed up there.
Oh, good. Excellent. And where are you located?
In Gloucester, Massachusetts, about 45 minutes north of Boston.
Okay. How did you hear about AnCan?
I was on a zero cancer support group last week, and the gentleman on the group was Zoom chatting with me on the side, and he suggested I give him a call, and he and I exchanged a bunch of emails, and I couldn't figure out how to get on, and then he sent me an email earlier today and told me about this group meeting at 8 o'clock, and I thought it was another group. I am on active surveillance, so I'm glad to hear that, but I thought it was actually another group, so I'm glad it's active surveillance.
Excellent. And how old are you?
Was that Jim Marshall, any chance?
Yeah, Jim Marshall, correct.
Oh, good.
I just wanted to double check that.
Very good.
Yep. Yep, he's been very helpful.
Excellent. Well, welcome again. How old are you?
I'll be 70 on Sunday.
Ooh, happy birthday.
Thank you.
Yeah,
Happy birthday.
we'll make sure as a group here, sign a card and send it to you.
Perfect. And
Actually,
sing happy birthday.
I wouldn't wait for it.
And are you a veteran by chance?
No, I'm not.
Okay. What year were you first diagnosed with prostate cancer?
January of 2023.
Okay. And how did you find out? Was it a biopsy done? What was your basically, how did it come about?
PSA. My PSA going into 23 was a 3.5, and then my annual physical, my PSA was a 6 point. No, it was an 8.2, and I flipped out. I have no idea what was going on. My PCP suggested I meet with the urologist, which I did. He did another PSA the following week where I didn't ride my bike before and I didn't have sex for 2 days before,
Good.
and that was a 6.1.
Okay.
And then since then, it's been slowly going up. I had it progressed to a 7.4, then a 7.8, then an 8.7 was a year ago. December of 24 was an 8.7. And coincidentally, I just had a PSA done yesterday, or day, yeah, yesterday, and it's an 8.54. So really, and I'm meeting with a physician's assistant for my urologist tomorrow. So this is great timing. I'm not sure what the 8.54 means. I've had 4 biopsies. I've had 3 MRIs.
You've had 4 biopsies since 2023?
Correct.
Holy smokes.
That seems like
All
a
all transperineal.
good.
The most recent one was in June of 25, so basically 6 months ago. They found no cancer. The previous 2 before that, they found cancer in 10% of one sample, and my Gleason 6 is 3.3. The first biopsy I did, they found no cancer. That was in 23.
Huh.
I guess your MRI showed no pyrids or any kind of lesions.
That's a question I can't answer. I'm not sure.
You had,
Uh,
Jim, did you have MRIs before every biopsy?
yes, and one that I had done on this very fancy suite at Mass General Brigham called the Amigo Suite, where they did a MRI simultaneously while doing the biopsy. They called it, and you guys are probably much more familiar with this than I. And
Was it an ultrasound while they were doing
no,
it?
No,
It's
they
an
called
MRI.
it's the inbore
yes, correct.
biopsy. Yeah.
Yes, that's right, exactly. I had that done in June of 23, and that was a Gleason 6 lesion.
So
And
they
then in
did find
December,
they did find a lesion then?
yes, that's
Ah,
that's what it says. And then in December of 24, I had a 1 lesion, a Gleason 6. And then in June of 25, I had an MRI guided biopsy with no lesions and no cancer. Or no, those are my words, no cancer, no lesions in the
right.
samples.
So 4 biopsies, 2 of which had 1 core Gleason 6.
That's
The first,
correct.
Wow.
was that
3
the
plus
first or
3.
the second one? Or both?
That
Or the
was the second. The first and the fourth showed nothing. The second and the third had the Gleason 6.
ah. So I wonder why they wanted to do a biopsy the second time if they showed no cancer in the first MRI and biopsy.
I insisted on it because the MRI, the first MRI I had showed 3 to 4 lesions, rad 4 and 5, whatever that means.
Pyrad.
IRAD.
And okay, yeah, and then I had a biopsy right after that, which showed no cancer, or nothing. And at that point, I had I was like, well, what's right? Is there no cancer, or is the MRI right, or the biopsy right?
Mm,
And so I insisted on having another biopsy that I had done at Mass General, like basically 5 months later, and that's when they did find the Gleason. And the urologist, it was a Zoom call when he called to give me the findings, and he was anticipating that there was no cancer. He goes, "Let me take a look at this, but I'm sure it's great news." And then he went, "Oh, well, actually," I was like, "Okay, great." So,
Can I
and
ask
then
a question?
yes,
I just wanted to confirm what I thought I heard. Did you end up having MRIs that showed nothing?
yes.
Has anybody ever mentioned to you anything about MRI and visible lesions and how that could be good news?
No, I take that back. Excuse me. I did not have MRIs that showed nothing. I had 2 biopsies where there were no, in the samples there was nothing. No, I
Ah,
did not have MRIs that showed nothing. Stand corrected.
gotcha. Thank you.
Could I ask a
Yeah.
Ian,
question? So Jim,
the first biopsy was negative. Was that a did they do that with either ultrasound or MRI targeting, or was that just a completely random, where they take 13 cores from wherever and hope they
hmm
hit something? And the second one that was positive was targeted in the machine.
I don't know for sure. I would assume, that, I mean, the MRI was done on February 9th of 23, and that's said 3 to 4 lesions, rad 4 and 5. And then the biopsy was done basically 3 weeks later. So I would assume, I don't know. I'd have to go back and look at the records. I'm not sure.
Did they talk about that being a fusion biopsy where the biopsy equipment was fused with the MRI image, or you don't remember?
Yes. Yeah. Yes, they did.
So Jim, would you say all of your biopsies were fusion guided?
Yes.
And is it, just zooming back a little bit, is all this under the same doctor or different doctors?
The first biopsy was a different urologist. The last 3 have been under the same urologist and the same radiologist, 2 of which
Okay.
showed cancer, and the last one did not show cancer.
What about the labs you've been getting your PSA? Is it all the same lab?
The last 1, 2, 3, 4, 5, the last 5 have been the same lab, and they've gone from September of 23 at the same lab with a 6.1, and then most recently, December 9th of 25 with an 8.5 at the same lab.
So a slight upward trend, but nothing too crazy.
Oh,
But your last
that's
MRI, or sorry, your last biopsy was negative with
But
the,
your last MRI showed nothing.
no, that's if I said that I misspoke. No, my last
Okay.
MRI was December of 24, and it did show one lesion Gleason 6 mid-gland peripheral zone.
But did they put a PIRADS number on it, a 4 or a 5 like the other ones?
I don't know. I made notes on it. I don't have those notes. I'm not sure.
Can I ask a question, Jim? What you just said, you said the MRI showed a Gleason 6 lesion. MRIs can't
They
detect
can't do
cancer.
that. Yeah.
You have to have a
Okay.
biopsy to
yeah,
detect the cancer. So if you had an MRI and someone told you had a Gleason 6 lesion, then
Full of
run to a
shit.
different facility.
Okay. Well, these are my
Yeah.
annotated notes, so I could be
Yeah.
wrong.
And let me
I-
clarify that real quick. So
Yeah, go ahead.
MRIs are PIRADS scores, and biopsies are Gleason scores.
Okay.
They can get confusing because you got Gleason numbers, you got PIRAD numbers, and MRIs and biopsies. So just to clarify, MRIs are PIRADs and
Yeah.
lesion with scanning. No cutting, no needles. It's just MRI. And then a
Right.
biopsy is usually needles and cores taken out. And they grade the cancer based on eyes under a microscope and giving you a Gleason
Okay.
score.
Well, while we're talking, I'm gonna see if I can go in and look at the MRI.
Sure.
I will do one thing, Jim. I had a friend before he came to AnCan. I knew him before then, but in a similar situation. He had a TURP, and when they have a TURP, it's a transurethral resection to clear out your urethra. If you're not familiar with it, they test the material for cancer also, because he had a slightly elevated PSA. And they said they found prostate cancer from the TURP. Then he had an MRI that didn't show any lesions, but he had a biopsy that showed a very small amount of prostate cancer. And the doctor said, well, go on active surveillance, don't worry about it, and come back in 6 months for a blood test, and then maybe next year we'll do another biopsy. The second biopsy was negative, and then a year later, a third biopsy was negative. He has not been diagnosed with prostate cancer since the first biopsy. So and he's going on for 4 years now. So
I think Howard's got that beat, right? Howard, how long has it been since they found any in you?
Well, I was first diagnosed in 2010, a single core of Gleason 6. And doctor wanted me to immediately have surgery. And I said a single core out of 14, Gleason 6. And I found a second opinion from Dr. Egner at the University of Chicago. And Egner said, yeah, well, I mean, the first doctor said, I have good news and bad news. And maybe some of you guys have heard this routine. So I said, well, what's the bad news? Well, he told me what he had already told me. You have prostate cancer, and he couldn't have been sadder. He didn't mention that I had low risk prostate cancer. And then what's the good news? Well, I can cure it in my operating room next Tuesday.
God.
So I got a second opinion from Dr. Egner, who had a new clinic for active surveillance at the University of Chicago. And Egner said, yeah, the first doctor could cure it, but I'm not so sure you need to have it cured. And he said, in fact, I'll go so far as to predict that in 10 years, it will not have grown. Well, in fact, every subsequent biopsy I had showed no cancer at all. I had something like 80 cores, and only one of them in 2010, was Gleason 6. I could have easily have been suckered in for surgery I didn't need and put myself at risk for the risks I didn't need. And so, a little bit of more of history. Back then, only 6% of us opted for active surveillance. And it was mainly in academic institutions. Now, this was 2010. Flash ahead to 2022, the latest numbers that we have, and 60% of American patients with low-risk prostate cancer choose active surveillance. Well, that sounds like great news, right? Well, that also means 40% don't. And if you're not aware of the international figures, in UK and Sweden, 95% of men in this boat go on active surveillance. And so you could say, well, maybe it's socialized medicine, but the state of Michigan has a special program endorsed by Blue Cross. Program's called Music, and I forget what all the letters stand for, but they have better than 90% uptake of active surveillance. So, but I can go on and on, but I won't. But at any rate, with you, is that what you're getting at?
Yeah, I was just wanting to
Yeah, it's 15
hear
years.
that it does. So, Jim, have you had any of your biopsies? Have you gotten second opinions on them?
With the slides themselves,
Yes.
I got a second opinion on the first one that showed no cancer. Have not gotten a second opinion on the 3 other slides. And just to answer your question about the MRIs, I just looked it up. The MRI I had in November of 23 was a PRIRAD4 mid-gland peripheral zone. And then the one I had in December of 24 was a PIRAD4 0.6 centimeter focal lesion. That's what I got quickly.
Yeah.
Thank
So to sum up, you've got a PSA that's running, that keeps on building, and you got MRI scores that say there's should be something, and then you've got these biopsies that aren't finding anything.
Well, two out of the four did.
I have a
Right.
question about
Yeah.
that. Was it the third one that had some form of Gleason score? The
The
third
third,
biopsy?
yes, the second and third both had Gleason score 6.
I'd like to touch on that. So, of those two, how many cores were positive with some sort of Gleason number attached?
Oh, wow. Now you're really challenging me.
Sorry.
Now you're really
Where
working
were
me.
you the night
Oh,
of September 12th, 2022?
shit. Hold on, I can
Because it sounds like
find that out.
you're very low risk and active surveillance is a definite possibility for you.
Well,
But
my
I just want to make
urologist said,
sure what your
yeah, my
volume is.
urologist, yeah, my prostate volume is 72.6 milliliters. That was a question.
That's
Um,
pretty big, huh?
yeah, I
How,
know.
how old are you?
70.
70. Well, and you know, you live in Gloucester. Is that what you
Yeah,
said? Why don't you go to you know, one of the major facilities in Boston?
I am.
You know, and you
No,
are.
I am. Yeah, I'm going to Mass General Brigham. My urologist is Dr. Keibel. He's the
Oh,
head of head of urology at
yeah,
Mass General Brigham.
yeah. He's an interesting guy. He is one of the tops in the field, but there's been a whole debate on whether to rename Gleason 6 as a non-cancer.
Right,
And because most people that get it will never have a spread if they have, quote, pure Gleason 6. Some guys have a lot of Gleason 6, and some doctors won't let them go on active surveillance. By a lot, I mean more than 3 cores. Keibel was leading the charge against any change. That's where I know him from. I'm not
he
saying that's bad or good, but I'm just saying he was one of the doctors who felt that if you changed Gleason 6 and called it a non-cancer or a pre-cancer, men would not be motivated to go in for active surveillance. You know, some of this is religion and philosophy rather than science. So, at any rate,
he yeah, well, it's funny you say that because he shared a couple things with me. He said, one, if you want to have your prostate removed, I'm not going to do it. You're going to have to go find somebody else. He said I would definitely not take it out. And secondly, he did talk to me about this discussion that some people want to make a Gleason 6 a non-cancer. And he said, trust me, you have cancer. And he said to me, you're going to go on active surveillance and just do what I tell you to do. He said a lot of people, when a Gleason 6 on active surveillance, they don't follow up and it causes problems. So just do what I tell you. My only issue with him, he's just so damn busy. I mean, my Zoom meetings last, I don't know, 13, 14 minutes, and and I feel like saying, I have cancer, can't you give me more? And I know he's probably dealing with 1,000 patients. I don't know.
well,
But
Jim,
I did get
psychologically, how are you handling this? You know, are
I
you?
think I
Go
feel
ahead.
really, I feel like I'm handling it really well. Um, I'm married. I have 2 adult daughters. They're both married. They're all aware of what's going on. I feel okay about it. I'm a pretty spiritual person. Um, and I I'm okay with it. I'm not okay with it, but it's in a very strange way. I know it may sound bizarre, but in a very strange way, it's changed my life in many ways for a positive, quite frankly.
There
Oh,
you
that's
Um,
go.
very, very common because it's almost like a second chance. It kind of gives
yes,
you a time to reconsider what you've done with your life up to now and what you might do in terms of how you act and how you take care of yourself. So it's very common for guys who, you know, especially, well, I think it's common for anybody that gets diagnosed with any cancer, actually. But we, you know, if you have low risk cancer, it's really a good time to change your diet, start exercising, do the things that you should have been doing. So
Yeah,
did any,
I agree with that. I'm an active athlete. I've done several Ironman triathlons. I run marathons. I do a lot of open water swimming. So I think on the exercise diet area, I'm pretty good. I'm very pleased with that. And um, as my friends say to me, you're like the healthiest person I know, but you have cancer. I'm like, yeah, uh-huh. So, but it's given me I just seem to be much more present in my day-to-day life. I appreciate and I'm much more grateful for everything that's happening in my life, my family, my wife. And so I don't want to belabor the point, but
Jim,
I
basically a lot of us have what used to be called autopsy cancers. They didn't find them until they did an autopsy from when you died from something else. And that's kind of the situation of everybody here for the most part. Chances are our cancers are not going to spread. Chances are our cancers are not going to kill us. And the thing to really be worried about is your heart. So,
It sounds
yeah,
like your lifestyle is done. Your lifestyle choices are very good. So
Jim,
if you
on
can
a
find out more about your last biopsy that had a Gleason score and know the cores. But just
yeah,
to give you some context, I'm Gleason 6, but I have 11 cores that were positive. So I'm called high volume. So my next step is to get another biopsy and see what's going on, if there's been any changes from 2 years ago.
well, and it kind of depends which doctor you talk to, like Dr. Catalona here in Chicago, who is responsible for the introduction of the PSA for screening. He used to be against active surveillance. Now he supports it, but if you're high volume, he thinks you ought to get treated. If you go to somebody like Egner or Klotz in Canada, they would support you, Eric. You probably know all that.
Yep.
So
Thanks for your help too on that.
Hey,
So can
Jim,
we
do
help
you have,
Jim out a little bit more? Because we have some information. I think the thing that he's got to wrestle with now is the gradually drifting up PSA, which constantly reminds him, as he said, that he's a healthy guy, but he still has cancer. So there are guys in the room, as we get older, it's normal for our PSA to rise, but it's very hard to get the urologist to say what number is okay and what number they're worried about. So Howard, someone like you, how much can Jim expect his PSA to rise just from benign prostatic hypertrophy and aging, and how much should he start to worry about?
well, I can just speak from personal experience. I mean,
Yeah, that's helpful.
15 years ago, I was edging up towards the magic 4 as far as PSA. I'm 15 years older now. I'm pushing 80, and my PSA for the last 10 years stabilized between 4.8 and 5.2, which percentage-wise seems significant, but like I'm considered at this age kind of in the semi-normal range. 6.5, for example, would be more worrisome. But you can't drive yourself crazy about a particular number. You need somebody like Dr. Keibel who can look at the whole situation overall and assess where you're at. I mean, yeah, you may have a 4 and a 5, but look, he's telling you you're safe on active surveillance, but you need to follow through. You need to be monitored. You need to have PSAs. You need to have MRIs. So, yeah, I don't know. I mean, that's my experience. I mean, I don't know that I'm typical. I mean, at age 75, I thought about kicking the whole thing and leaving. I talked to 16 of the top doctors in the world. And I said, what do you think I should do? And they didn't agree. There was no consensus. 4 of them said I should just, turn around, walk away, and stop active surveillance because nothing's ever going to happen to me. Two of the doctors, Dr. Catalona, who I mentioned, and my own doctor, Dr. Helfand, both said, well, you might think about getting an occasional MRI. So, Jim, it's very individualized.
Jim, can I ask you a couple questions? Did you ever have a genomics test of your tumor?
No,
No. Okay. Anyone suggest that or no? Like a
I've never heard of
Decipher
it.
test or no?
Well,
No.
Well, to
you
follow
really,
up on that, is any family history as well with prostate cancer?
No.
Did
My uncle
they
had
do?
lung cancer, but there's no prostate cancer.
Ray, why don't you talk to him about genomics?
Yeah. So there are several tests. There's Decipher, Polaris, Oncotype, I think is the other one. Basically, it's a genetic test of the tumor itself. And they split it up into basically slow growing, medium, and high. So that might either give you some comfort or cause you to want to watch it more. The other question I was going to ask you is, did they give you a free PSA score when they did your PSA?
I did have a free PSA. One of my PSAs is a free PSA, and I don't remember which one it was. I think it was, uh, I do know which one it was. I'm 99% sure the free PSA was a 7.8, and that was a year and a half ago.
No, the free PSA number would have been, it either would have been given as a percentage or 7.8 was probably the regular PSA. Was there a smaller
Oh,
percentage that was a free PSA, a smaller number?
okay. I have the free PSA results right in front of me.
Okay, what does it say?
1.0.
Okay,
Is
so
that
that
is that
1,
NG per milliliter?
yeah, 1.0, and then it was a 7.8.
Yes.
Well,
Is that bad or good? You guys are quiet.
the lower the free PSA, the more likely it is that you have cancer. But we already know you have cancer,
Yeah.
so
What does your doctor want to do going forward in the active surveillance? What is his protocol?
Well, I'm going to meet with the physician's assistant tomorrow, and I'm going to ask her, what do we do next? I don't have another meeting with with Kybel until June, unless I insist on it sooner. But I'm meeting with the PA tomorrow. When I last spoke to him in June of this year, 6 months ago, he said that at that point, he said, we're going to do a PSA every 6 months. And I don't think you'll need another biopsy for 2 to 3 years unless we see a change in the PSA.
That's
Didn't
excellent.
mention MRI at all.
That's all good.
I would
Would think
definitely
an
consider,
annual MRI would be good.
yeah, I concur. Or at least talk about it as an option to have an MRI once a year.
Should I request, my question is, this has been extremely helpful for me. I just want to say that right up front. I'm meeting with the PA tomorrow. So what I've heard is talk about genomic testing, ask, what's her assessment on the gradually rising PSA, do an annual MRI. Is there, one of the things I was thinking, should I request a PSA instead of every 6 months, every 3 months, or every 4 months?
Good. I'm on every 3 months.
yeah, I mean the problem with it, you start living from blood test to blood test, and your anxiety goes up, and whatever you've got, it's not moving very fast. I mean, if it makes you feel better to know the number, great. But if it doesn't, I don't think something's going to escape you in 6 months. So, that's pretty much
Okay.
your call.
You brought up the genomic part, but you should also bring up the germline part. Germline testing looks at the genes you inherit from your mother and father, and it isn't just a male thing. Like BRCA testing, BRCA is short for breast cancer, but it can be associated with prostate and a number of other cancers. And there's a free test called the PROMISE test from a study at Johns Hopkins. You mentioned the lung cancer. Well, that's probably a whole different animal, but maybe there's people in your background who've had breast cancer or pancreatic cancer. Some of these are linked to germline testing. So ask the person you're seeing about germline testing and the PROMISE study at Johns Hopkins.
Okay.
Hey,
What about
hey,
I'll put a link in for the PROMISE study in the chat window for you right now. Free. You got it. You got it already. Thanks, Eric.
Yeah.
one other question? What about a PSMA? Is that something I should be asking about, or
No,
Not now.
No.
Too early. Way too early.
okay?
But if you do the genomics test, they need to take it from your biopsies that had positive cores, and those are the ones that are sent off for testing. So it'd be the second or the third.
Test is a spit test, so it's a different animal.
Okay.
Well, Howard's talking about the germline testing.
Yeah.
You can get that from any cell, but yeah. But what Ray was talking about can come from the biopsies that have already been done.
Yeah. Derek,
have
you have
to-
a question?
I had a question for Jim regarding the MRIs. I know you said you're at Mass General. I assume they're considered a center of excellence, medically wise. Do you happen to know the resolution of the MRI machines that they're utilizing for your scans, or does it mention
Would
it
it
there in your
be-
paper? The
be
T
in
number or
my,
Tesla number?
1.5
what
or
would it
3?
be?
1.5 or 3?
Correct.
3 Tesla or 3T MRI?
And just because it's a 3 doesn't mean that that's the best one. If you have a new 1.5, it might do a better job than an old 3.
Really?
Yeah.
Where would it? I'm looking at the results
Even
right
though we're
now.
talking about resolution.
It'll be on your radiology reports or MRI report.
That's the strength of the magnet. Don't think
Oh.
about the car, think about the scientist.
Got it.
Hard to imagine that Mass General wouldn't be using state-of-the-art stuff.
Agreed.
Well, a
So-
lot of centers have a mix of 1.5s and 3s, and like there is a 7 now, but you got to be thin as a rail, and it's really experimental at this point.
See, one thing, it says peripheral zone, patchy area of low T2 weighted signal. I don't know if that means anything. Oh no, here it is. Multiplanar MR imaging of the pelvis was performed using T1, T2 fat saturated diffusion weighted techniques. Does that
No,
answer the
that's
question?
that's the protocol they're using. That's not describing the machine.
Okay.
So
I'm working
Jim,
on it, guys.
Jim,
if
what
there's-
can we do? What
if they're
can we
seeing-
do
if
for
they're
you? I
seeing
need
stuff-
to.
Yeah, if they're
I need to
seeing
kind
stuff
of,
on his MRI, he's got a
Yeah,
strong
we-
enough machine.
Yeah. Jim, do you have any more questions for us at this
Um,
point?
No, what I heard is I'm going to meet with the PA tomorrow. I guess as a group, is there anything that anybody's saying that, active surveillance is not the appropriate thing for me right now, or no?
This group is not going to tell you that because you're active surveillance.
Yeah, all your
All of us.
numbers.
Yeah.
Your numbers scream active surveillance.
But
Okay.
that means, just like we told you, you have to be active with it. So
Yeah.
Yeah.
I'm going to catch one. I'm going to
Yeah.
catch one guy here. Albert had his hand up, and then Jim, if you don't mind, we need to catch a couple of other guys, and if we got time at the end here, we can come back with any other questions that you got. Albert, go ahead. What was your question?
Albert,
Albert,
unmute.
you're
I can
unmuted.
hear you. You're muted.
Yeah, I wanted to clarify, Jim, that you received an in-bore live MRI biopsy.
Yes.
Okay. And I'll ask the group, is that sort of the gold standard now? And like I'm due for a transperineal, but not live in-bore MRI. It's, it's MRI fusion, but it's not live MRI. Is one missing out if you don't do the live MRI?
It's definitely the high end of the biopsy world, but I'm sure the fusion guided, as long as the MRI was pretty recent, I don't think there's a dire need for live imaging.
It's
Maybe
it's very, very difficult to do any kind of procedure like that in the MRI suite. You can't use any ferromagnetic tools or instruments, and I wouldn't run around looking for places that do that. That's got to be an exception.
Yeah.
And I'd add another point to that, and I think Howard would probably agree with me, which is that one of the problems with doing a rectal procedure, which the MRI in-bore is that there's a lot of occult areas, meaning hidden areas that we can't really see. I don't know if an in-bore MRI does a good job. Howard may do on the anterior, but even if it does do a good job on showing the anterior, I don't see how they can get to it.
No,
Gyms were all transperineal, were they
Yeah,
not?
gyms
Jim?
are all transperineal. So they can do it both ways, it sounds like.
You're saying the MRI in-bore is transperineal?
Yes. It was performed at Mass General at the Brigham and Women's Hospital, or Mass General. It's called the Amigo Suite. It's pretty unbelievable place. They just had an opening. That's why I went there, and I didn't really know anything about it.
That's been corrected. I'm trying to imagine how you do it. I'm trying to imagine how on earth you can get somebody into an MRI when they got their legs in the stirrups.
No, I mean, yeah, it's pretty strange. And then the needles, you have to use either all titanium equipment or plastic. You can't use anything made out of normal metal because it'll get sucked right into the machine.
I don't think everybody needs to be looking to have that done. I think it's an outlier. There's only a few centers that offer that.
Okay, guys, let's see if we can catch Martin here, who's first time, Martin. And Dan, I think you are going to go ahead and run through the questions for him.
Sure. So, Martin, you heard pretty much the series of questions. So,
I sure did. Yep.
So where are you located?
In Evanston, Illinois.
Okay.
Howard, where are you?
I'm in Flossmoor, Illinois.
Okay.
And we should connect because
I agree.
We have a local group that meets in person quarterly, and we need you there, Martin. And we meet in Oak Brook, Illinois, in the middle.
I said, "Oi, that's a ways."
Well, should I need to have to go all the way up to Evanston? I actually do. I go up to North Shore. I see Dr. Helfand there.
Dr. Helfand, yeah.
But who do you see?
Well, I see right now I'm in the process of figuring this whole thing out because I was just diagnosed recently.
We should talk one-on-one.
Yeah, let's do that.
Why don't you put your email address in the box, and I'll send you a note.
Howard, I can provide you his email address and everything. He was in the lower intermediate group, and I suggested he come over here and talk to you guys because of the results.
If Howard, could I have yours too then? Bill, can you send me Howard's too when you?
Well, I'll put mine in there.
Sure. I don't know which one of you has an upset cat, but
yes, it's my cat. Sorry,
coming through loud and clear.
All right,
Okay.
Juno, you have to go away.
I can run through some of the information on Martin, and he can correct me if I get something wrong.
Okay,
if
I'm
that's
gonna
all
get
right.
my cat out of here. 1 second.
Okay. Why
Sorry.
don't you hold
Sorry
on?
about
it
that.
Is it a male cat? Does he have a prostate?
No, it's a female cat who wants to be fed. Sorry. Come on, Juno.
Cat prostates are not what we normally discuss here.
Yeah.
Cats
Dan,
don't
you're
have
opening up
perverts.
a different can of worms over there.
Yeah. Bill, fill
Okay.
us in and Dan take over after that.
Okay, Bill, why
All
don't
right,
you,
sorry about that.
Bill, why
Yeah,
don't
let
you
me,
give us some background, and then Dan, step in there where you need to.
Yep.
Martin, please correct me if I get something wrong. I did take
I
some
will.
brief notes when we were just talking the other day, but you know, to shorten our time frame here, you had basically you had a PSA rise, you had an MRI that showed a lesion, and then you had a biopsy. It was a transperineal fusion guided biopsy.
Correct.
So I'm good so far, right?
Yep.
So his highest PSA score was, correct me, 4 point something, you said?
Well, no, it was originally 2.75, and then after the biopsy, I had one, and it went to 7.54. But one doctor suggested that it was high due to the fact that I had the biopsy.
Yeah, how soon after the biopsy was the PSA score taken?
About 3 weeks, maybe.
Oh, that's way too early.
Yeah.
Yeah.
Yeah, that's wrong.
So
Throw that
anyway,
out.
he didn't have his biopsy report when we first started talking. He did send it to me, and he had one positive core out of 14. It was 0.5 millimeters and came out to less than 5% of the total biopsy. And then he did have Dr. John look at his Decipher score, and I did not write down what Dr. John came out of that, but he said his Decipher score was very low.
It was, yeah.
I remember that.
I did have a Gleason
Bill,
of 4
Bill,
plus 3.
Bill, the one core was a Gleason 6.
It was a
7.
4 plus 3, 7. So
It was a
I was
4 plus
I was getting
3,
there.
7.
Okay. Yeah.
It was less than
So
5%.
Okay.
It was 0.5 millimeters and said less than 5% of the biopsy. So I was
Nothing
assuming,
about
Second opinion.
Or
yeah. So he has sent his slides to Dr. Epstein, but as of a couple of nights ago, you didn't have a response yet, right?
Right, and still don't.
Okay. It's only been about you said a week?
A little more than, well, I sent it. It would have been, I spoke to my urology office for them to send things and, have them, and I think that was before Thanksgiving. So, it's possible with the holidays and everything that, it was a delay.
Well, more than likely slowed it down. So,
Yeah.
and I had a second set, another few notes on you, but I think I covered them just by saying that.
You did.
Is there anything else you would like to add that I didn't cover, Martin?
Well, no, it's just, I know that this is not necessarily it's only extra surveillance, but I'm still trying to figure out what to do. And that's my issue. I've spoken to different people, one who does cryo, one who does HIFU, one who does radiation. And I'm just so confused.
And when you first came to the low group, you mentioned those things, but we hadn't seen your biopsy yet or your Decipher score. And then when you brought those to us, we were like, you don't have a lot of cancer, right?
Right.
But the fact that it was a 4 plus 3, I thought you should come talk to these guys.
No, I agree. Thank you. I mean, it's good to be here.
Well, I mean, honestly, with 4 plus 3, you really got to wait for that second opinion to see if Dr. Epstein backs that up. I've seen many men who've had their scores reversed. So I would try to remain calm and not freak out.
I know that's what everybody tells me. Easier said than done.
Well, you got to do it.
Martin, we had a guy.
We understand that, right?
Yeah. Martin, we had a guy last night. in the high risk recurrent advanced group who thought he was 5+4, if I remember, certainly 4, but I can't remember if it was 5+4 or 4+5. I think he was 5+4 and was going down this path of treatment and hormone therapy. He sent his stuff out to Epstein. It came back as a 4+3.
Okay.
So it completely changes the ball game. And for you, the key issue when I think about this that I would be drilling down with my doc is, yes, you're a 4+3. You may not even be a 4+3, but yes, you're a 4+3 because who's read those slides so far? Was it Northwestern or was it your local pathologist?
Northwestern has read it. Everyone there, the urologist read it.
Okay, so the pathologist who's read it is at Northwestern, which is not the same eye as sending it to Epstein. It's really chalk and cheese. It's completely different. But the bigger issue is you only have 0.5 millimeter. Now, I've seen guys that have had 4+4s with 0.5 millimeter. Back when I first started this, I remember a patient that Peter Carroll was treating. The guy was a 4+4 with a tiny little bit. And he went for a year and a half, 2 years like that. He had such a little bit of cancer. So yes, 4+3 normally needs treating. And the doctor's going to say, oh yeah, you've got to get treated. But you've got to get second opinions on that, even if you are a 4+3. Because with such a small amount of cancer, it does change the ball game.
Understood.
Yeah, I was raised, of course, on the imperial system here in America, and told that we would go to the metric system one day, and I'm still waiting. I'm 62. So I looked up what is the size of 0.5 millimeters. It says it's half the height of an average sheet of copy paper.
Oh wow. Yeah.
I mean, it's not even the size of a BB. It's the size of a pinhead. So you, as Rick said, you have a very small amount of cancer. Yes, it was diagnosed as a 4+7. I mean a 4+3, but yeah,
Right.
get that. Let's wait for that second opinion. Run out and ask someone to do focal treatment on you, because
Has Martin had an MRI?
Yes, I had the MRI first, which then led me to the biopsy, which then led me to the PET scan. The PET scan was fine. There was no metastasis at all. So,
what was your PIRAD score on the MRI?
Yeah, I'm sorry, I do not have I never got a report.
Okay.
I got the disc, but I don't have the report.
Okay, was that a fusion biopsy? I mean, did they do a fusion with the MRI when they did the biopsy?
I believe so. Yes.
Okay.
So they saw something.
Let me go back a couple things. So, are you a veteran, perhaps, Martin?
No.
Okay. And how old are you again?
67.
Okay. So, and you signed up for the reminders, and you're good. Bill's got all your information, so you're good from there. And you heard about us from you already some other meetings.
Right. I heard for you from the guy who does the cryotherapy. His PA gave me Jim Straight's information, and then that's how I'm here. My dad did have prostate cancer.
Okay. So have you had any genomic testing?
No, not yet, but I'm thinking that.
Yeah, that's something that you want to do, as well as have you had any genetic testing, like Howard mentioned the PROMISE study that was going on?
But I would definitely look into that.
Yes, since your dad had prostate cancer, it's not necessarily likely, but at least you want to cross that one off. You mentioned that you're kind of easier said than done on slowing down. So how are you doing emotionally, psychologically with your diagnosis?
Well, I go from being okay to it to being really anxious about it, and feeling that since I've got cancer, I've got to do something about it.
So we've got a group called Men Speaking Freely. Most of the guys on there are prostate cancer patients. Most of them have already had some treatment, so you can kind of hear some of the things that they've been through and the issues that they are running through. But it's just it's a place for you to be able to just, hey, here's what I'm thinking. And guys there's usually anywhere between 10 and 20 folks, and they've all been through it. We all get it. So that's a good place to jump in. And if you need a link to that, I don't know what the date is off the top of my noggin, but that's a good group to be in as well.
Okay, I can Google that, or
here's what we'll do, Martin. I'll add that reminder to your reminders.
Okay.
The one thing that you should know is we don't talk about treatment. You can talk about your anxiety and what it's doing, but we don't speak about treatment in that group.
That's fine.
Okay. Yeah. We'll send it to you. The next meeting
I've not
is
had any reminders from anybody other than the only reason, I mean, I got the information about this from Bill, but
well, this reminder went out 2 or 3 days. Our reminders go out about 24 to 48 hours beforehand. So you probably weren't signed up in time. We'll send you the reminder for this meeting just so you can see what's in there.
Okay.
And the next active surveillance, the next Men Speaking Freely will be on the 18th. And you'll get that, and you'll also get the low moderate. And I'll take care of that right now for you.
Thank you.
So Martin, I think to deal with the anxiety, it helps to kind of feel like you're fighting back a little bit. The first thing I would think is you got to get a provider that's on the same wavelength as you. The people you're seeing now, have they mentioned active surveillance, or are they more interested in yanking your prostate out?
No one has talked about yanking that out. Because I made the decision that I wouldn't even discuss that. I've been looking mostly at a couple of focal therapy things and then radiation.
So I think you need to get with somebody I don't know, you can talk to other members of the group here who they're with, but you're going to feel a lot better if you feel like someone's in your corner, with you and lays out a plan. We'll get an MRI every, year. We'll get a PSA every, 3 or 6 months. And then at least you'll have a plan you can follow.
Well, I can do that with my urologist, who I really like a great deal.
Well, but that's sometimes the problem. Urologists, it's like going to Midas and asking them if you need a muffler. I mean, urologists make their living operating. They're surgeons by training. So, if he says, yeah, great, you're a great candidate for active surveillance, let's do it, great. But if he's not giving you the whole picture, then you need to talk to someone in the group here who lives near you that can steer you to someone that can be in your corner.
Okay.
If you get with Howard, you'll get some really good information.
Yeah,
Howard's been with us for a really long time. And he's also a medical writer, so he's well in tune with a lot of research, so he can help you out with that.
Sounds like a plan.
I think we have hit most of the questions by happenstance. So what questions do you have, Martin? What can we do for you that we haven't done already, other than maybe assuage some of your fears?
Well, I guess I'm kind of confused if people have really high PSAs.
Define high PSA from your perspective.
Well, to me, like 8 or 9 is high.
Okay. Well,
but
there's a lot of mythology that goes with that. I mean, they put it in your head that if you're heading towards 10, you're in trouble. But I can tell you, Dr. Todd Morgan at the University of Michigan, who supports this group, by the way, he once told me patients are focused on that 10. He said he doesn't really start worrying about it until it hits 15. And I know plenty of guys who have it 70 and it can go into the thousands. So
wow.
I don't know if that gives you some perspective.
No, it does. It does. I think, again, was it Ray, I think, or Dan was talking about, Dan, about having so many tests so quickly, then you're like almost getting so nervous about the next test,
Martin, this may be repetitive for you, but we talked about this briefly earlier in the session, but about the do's and don'ts before PSA testing.
Yes.
Okay, good.
That's good.
And
So when
consistency
is your
of-
next appointment with your urologist?
January 7th.
Okay.
Who is your urologist, if you don't mind?
Gordon Gluckman through Euro Partners.
Well, Euro Partners, okay. I mean, they're a private group, and they're one of the biggest, certainly in Chicago, but also nationally. I know their CEO. I know, I know what he sells. So you're actually, you're not technically at Northwestern, right?
I am for no. I mean, that's where I'm seeing doctors, but that urologist, in other words, there, right?
Who's your urologist at Northwestern?
There isn't one. I don't have one at Northwestern. I have
Oh,
I've been
okay.
going to Northwestern for talking to people for surgery or treatment.
So, Martin, are you familiar with how much have you done on the AnCan website and looked at the things that are there?
Not much.
Okay, so you've got some time. You got a couple of weeks before your appointment. What I would suggest is go on and look at the resources tab on the website, and there's a lot of recordings, and specifically on you can listen to some of the active surveillance, the conversations. You've heard some of those here. These are routine, but it'll give you more information. I would also advise you to look at some of the resources in that resources tab and gather more information. Key thing for you at this point, from my perspective, is you have to be your own best advocate. And the way you do that is you get informed.
Right.
And the way you get informed is you come to meetings like this, and we're going to have another one next week on Wednesday, same time, same bat channel. You're same age, so you know what I'm talking about. But also dig in and do your research and see the things that are there. There's a host of information available, not just on AnCan, but there's the PCF, there's PCRI, there's a host of places that you can go to find good information. So do your research, and so that you are well informed when you go and have your conversation with your urologist, and come back again next week. And if you have dug in and you come back with more questions, absolutely, we will ask you at the beginning, hey, do you have anything to add? Do you need time? And if you do, jump in.
Well,
we are
also,
here for you to do that.
Thank you so much. And also, I do have to have a PSA before that. Do you think it's too soon if I have it like next week?
When was your last one?
Oh, well, it was after the biopsy, but I can't remember exactly when.
How long? Months?
A month. But
well, you know, that biopsy can kind of shake up the prostate.
I know, right. And so my urologist wants me to have one before I see him on January 7th. Should I wait till the first week of January, or can I have it like in a couple days?
I would wait.
Depends when the last time you. Depends when the last time you would. When was the last? It depends on when you last ejaculated and whether you're riding bikes and doing stuff like that.
Okay, well, all right. So I've been riding bikes, but obviously I'm not going to do that prior. I understand what you mean. Okay, but my point being, should I wait? Even if it was a month ago, whatever.
Personally, I would wait a little bit.
Okay.
Yeah.
Yeah. If your biopsy was on September 23rd, and you said you had that first PSA 3 weeks after that, so that was mid-October.
Right. And my
So
urologist
put it off.
My urologist wants me to have it by January. By see him on January 7th. I have an order for it. My question is,
a 48-hour prep time in order?
Yeah.
Get it in the first week in January.
Yes.
Thank you. That's my question. Thank you.
Get it at least 3 or 4 days before your appointment in case they're slow in the lab.
Okay.
And go to the same lab. Use the same lab for all your PSA testing.
Okay, I didn't know that. Okay, thank you.
Yes, definitely. All right.
Anything else?
We're going to try to catch.
Yep, I'm good.
Ahead,
thank
Dan.
you guys. You're fabulous.
Right.
Thanks so much.
Okay. We're going to try to catch some of the other guys' questions. So, Jim F., you wanted some time?
Hey, guys. Good to talk to you again. So I just got my second opinion back from Dr. Zhao at Mount Sinai. I used him just because I heard he was a little bit cheaper, but great to have a second opinion. It was interesting. A quick review. My original was 5 cores positive, 3.3, 3.3, 3.4, 3.4, with the 4s being 5 and 1/10%. And it came back just the opposite. Still 5 cores positive, but 4 cores at 3.3, 1 core at 3.4 at only 5%. So I think that it, obviously an improvement. If it wasn't for my PIRADS as a 2, if it wasn't for my 0.62 decipher score, it would be a little bit better news. But it was interesting because Dr. Zhao, it cost $345. I did have to have my doctor involved to get his ID medical number because they won't give it to you personally. They have to give it through your doctor. So that took a little bit of paperwork shuffling, but no big deal. But one of the nice things was Dr. Zhao would take a phone call. So I took a phone call with him. And what a great conversation, because you're talking to somebody who has no interest in profiting from you from being in surgery. He's one of those people that very much feel that 3+3 should be called precancerous at best, or not be called cancer at all, because people are rushing into this. He encouraged me to stay on active surveillance, which is really the first doctor, even Peter Carroll here in UCSF didn't seem to be a big fan of me being on active surveillance, which I was very surprised at. But it was a great conversation with Dr. Zhao. Great $345 spent, and gave me a real good talk. I thought it was really interesting.
That's great, Jim.
Good news.
It's always
nice Christmas present.
Yeah. Like I said, if I didn't have the stupid 0.62, I would feel much better about it. But really, I have 1 core. That's the 5% is the minimum they judge it by. So, diet, exercise, try to keep this thing slow growing as possible. And nobody knows when you have to make that jump. But until the 4 overcomes the 3, I feel like I can just, do my lifestyle as best I can and keep on top of it.
Well, that's great, Jim. And thanks for sharing. That means a lot here for the other guys to hear about doing that. So next I've got on my list, Dan.
Rick has his hand up.
Okay, I'm sorry. Yeah. Rick?
So, Jim, I bet dollars to donuts that if you gave Peter Carroll Dr. Zhao's new reading with 4 cores of 3+3 and 1 core of 3+4 and just a small amount, he'd also tell you do an active surveillance.
You know what? He told me to reach out to him. I had his email address. He says, reach out to me. So I did. He goes, yeah, I'll talk to you. I'll set up an appointment. It was going to cost me $400. And I thought, well, for an extra $400, maybe I don't need it because I'm not in network with him yet. So I turn 65 next year in October, and I'll be on Medicare.
So all I'm saying is I don't think it's fair to say not even Dr. Carroll said I shouldn't do wasn't aggressive on active surveillance. He wasn't aggressive because he didn't have the information that we all have right now.
Yeah, fair enough. It was the whole. Yeah, fair enough. That's a good point, Rick. Thanks.
Okay, Dan Pert. I forget how you pronounce his full name. Dan, are you here?
Yeah, like woodchuck, Perchuck. So yeah, I just wanted to ask. I sort of asked this before Howard weighed in on it, but those of us who are sort of, still pretty new at active surveillance, but we're all getting older. It's not surprising if our PSA goes up a little bit. I was just wondering what some of you who've been at this 5, 10, 15 years, what we can expect in terms of PSA rises. Now, Howard's didn't go up at all after a certain point. I think that's probably the exception, but maybe not. So anybody who's been at this for a while who wants to weigh in with what their PSA has been doing would be helpful for the group.
Bill Wood, you've been at it a while.
So I've been on active surveillance for 15 years, and 3 years ago, I became grade group 2, 3+4 with less than 5% pattern 4, but with cribiform. And my PSA has been slowly rising. And in October, it was 14.6.
Okay, that's great to know.
And my protocol is PSA every 3 months, and an MRI is required. And we're looking for prostate velocity, PSA velocity. And my PIRADS is 5, and my prostate density is 0.3 something. So I'm high prostate density, very high. But anyway, I'm 84.
Bill, you got to tell them how old you are.
I'm 84, and I was told that regardless of what I do, I probably won't. Prostate cancer will probably not affect my longevity. Before, my father died of prostate cancer in '92, but that was many decades ago. Without the treatments that are available today.
Well, that's great. That's very helpful.
You're welcome.
Okay. Steve K., you wanted some time.
Anybody else who has been on active surveillance for 7 years or more in the room today? Howard, you spoke up. How many years have you got, man?
15. This is I forget what they say in Spanish, but it's this
Quinceañera.
I'm having my quinceañera, and I'm going for a sweet 16. And 2 years ago, I had my pras mitzvah.
Anybody else? All right. Stephen K.
Hi, can you hear me?
Yep.
Yes.
Great. Yeah, so just a couple questions. When I visited for the first time a couple of months ago, the consensus was active surveillance was the correct decision at this time. And essentially, let's see, July of 2024 was when I had my first MRI, August, the biopsy. I had finally had a second MRI this month. And my question is then, is it then appropriate to have a second biopsy at some point? What's the kind of schedule do we look at for getting the next biopsy?
You're talking about a confirmation biopsy?
I've heard it called that.
Yeah, well, there's a whole debate on that. Dr. What's his name? Cooperberg at the University of California, San Francisco, came out with a study just in the last couple of weeks saying that you still needed a confirmation biopsy. But I can tell you in Europe, in England especially, they don't do that anymore. Some of them just rely on the MRIs. I mean, back in the day, they were trying to save us from surgery and radiation. These days, they're trying to save us from that, but they're also trying to save us from biopsies because they have their own problems. So, it kind of depends. If you see Dr. Cooperberg, he may want you to do that. But if you see Dr. Egner at UCLA, he might ask you to do something different. They don't really have solid guidelines for this.
Yeah, Steve, do you have a, I mean, if there was no visible MRI lesion when you had your first MRI and now there is a lesion, if there's something that they can target and go after, then it might be worth doing. But if there's nothing showing and they're just going to do the scatter, 14 scattered biopsies and hope they bump into something, I don't know. It's hard to recommend that.
Sure.
Yes, Steve, what was did you have a Decipher score or anything?
I've got my urologist went and got me a Polaris score. Mm-hmm. I was, well, I can tell you, let's see, I don't know if I have it handy. It was essentially the report, they were recommending it was intermediate and I should get treatment. My concern with Polaris is that in 2024, the NCCN, National Cancer Network, they have those recommendations, have listed Prolaris as unvalidated and has dropped Prolaris in 2025 anywhere in their literature. So I have doubts about the value of Prolaris as opposed to Decipher, which is still listed as an option. Yeah, with regard to Prolaris, I'm not putting a lot of weight on them telling me I should get treatment when I only had 5% of Gleason 4 in one core. Now I did on the second MRI that I just had, the one PIRADS 4 lesion was still there. A second PIRADS 4 lesion disappeared, and a new PIRADS 3 lesion appeared. I'm seeing my urologist next week. Hopefully he can explain to me what this means. But I don't quite follow what's going on with MRIs with lesions coming and going like that, especially PIRAD 4 lesions.
So one of the most common reasons for a new lesion to pop up is from bleeding after your first biopsy. But 3 is sort of right in the middle. If it's a 1 or a 2, you feel more comfortable if the radiologist will sometimes say it looks like blood or hematoma from the previous biopsy. I'm not sure what they're going to want to do with the information about a 3, and they may want to look at other things like a PSA and stuff like that.
So
right.
Steve, I'm over at MD Anderson, and when I went over there, I was just a 1 core 3+3 Gleason 6, and I didn't get a confirmatory biopsy for about 4 years. And so I got PSAs every 3 months and an annual MRI. And as long as I was staying within range, basically between 7 and 9 as far as my PSA, because it would bounce up and down, and the MRI wasn't showing any changes, then they postponed a biopsy. So I didn't have a confirmatory for 4 years.
Would you really consider that a confirmatory or more of a surveillance biopsy?
Well, I don't know what you want to call it, a confirmatory or it was my second biopsy is what I'm.
Well, the confirmatories typically were done 12 to 18 months after. Yours sounded like it was spaced out more like a regular protocol. I mean, back in olden times, we had biopsies every year.
Right.
I hope nobody in the group is experiencing that.
Yeah. So that was my experience.
Thank you. My second question just had to do with the fact that I'm still currently, I don't have a doctor who really supports active surveillance. I'm looking at, based on recommendations from here, I think it was Rick that recommended Dr. Frendel at Mayo Phoenix. So I'm going to be seeing Dr. Frendel next month, and perhaps he'll become my urologist. But if not, Denver is close enough to drive to. I don't know if anybody has any experience with doctors at the University of Colorado in Denver Cancer Center.
I'd have to look at the urologists. I certainly know about the medical oncologist there. I think there is someone. Do we have any Denver people in this group today? We have Denver people.
Yeah, like Mike Wynn would know, and
Mike Wynn would know. Yeah, good call. I mean, we can find you, but I don't. Howard, do you know anybody who's active?
Well, I know of one. I don't remember the name, and I just know Mike because he has the resources. He went to Toronto and saw clots, and he went to California. He went, everywhere but Denver.
Yeah,
I don't think he was too happy there, but that's not to say that there isn't somebody there in Denver.
I'll put Mike Wynn's I'll send you Mike Wynn's email. Just tell him that the group suggested you talk to him. But to be honest, I'm not holding my breath. So,
Okay.
and where are you based? I can't remember.
Yeah,
Albuquerque.
I'm in northern New Mexico near Santa Fe, the town of Los Alamos.
Yeah, that's
so
right. Yeah.
and New Mexico is not a state to get.
No.
Well, you remember Nancy and Larry, they were from Albuquerque. They ended up going to the Mayo Clinic. Well, they went to the Mayo Clinic in Phoenix and were unhappy with it. And they ended up going to the mothership in Rochester. And they weren't happy there either. And I think he ended up at UCLA.
Okay.
Yeah. Oh, I've got it. Here we go. I'll send this to you, but Steve, I'm not holding my breath for you. I still think you're probably best off from where you are, driving down to Phoenix.
Okay, very good. Thank you.
You betcha. Thank you. Albert, you needed some time. Albert, you're on mute.
Thank you. I had my MRI and I had my biopsy on Thursday. And if someone could post in the chat how to get in touch with Epstein for a second opinion. And people had also talked about getting a second opinion on the MRI. I don't have any names for that either.
The chat, there's already the second opinions for biopsies. It's way at the beginning.
Okay.
You've been on the whole. Yeah.
You have to click on that pin. You have to click the push pin for it to show.
Yeah, we pinned it at the top.
Oh, I see. Okay.
There's a little push pin with a red dot on it. And when you press that, you're going to get the information that you want.
Okay. Great. And then
and I'll put the we'll put the second opinions for MRIs in there too.
Okay, great. Thank you. So I guess it was Howard mentioned there's issues with MRIs, and in the past, I think I've asked over a year ago about the risk of cancer spreading from them doing the MRI. That would be my biggest fear.
Well, the doctor's first reaction to that is always, it doesn't happen. Untrue. I do a newsletter. I have an article coming up about it, and basically, it's rare. It mostly happens to guys with more advanced cancers. It doesn't happen to this group per se. And there's only case studies since 1953. There's maybe 50 recorded cases. So, do your own math, and if you think you're walking under a dark cloud, watch out for the traffic.
Right. Yeah. Okay. And then just to reiterate, I'm kind of a nervous Nelly about everything, and I'm like, I'm not getting a live MRI, and it's going to be substandard. But it seems like the consensus with the group would be just go ahead and get your MRI. It's fusion with Dr. Frendel in Phoenix. I like the guy, and I'm way over on my confirmation biopsy. So they had said 12 to 18 months. I'm at 31. And anybody have an opinion on that?
Well, look at Hugh. He was what, 4 years?
Yeah.
From your confirmation.
As long as the trend is your friend, and as long as I was within the band on my PSA, it would jump up and down between 7 and 9, and MRI that looked the same.
But that's not Albert, though. That's not Albert. There's a new lesion, and he's a 3-4, even though it's a small 4. Correct?
No, I don't have I have on the MRI, it showed a new lesion. It's pyrad
I read 2?
4.
A 4.
4.
Yeah.
What was the old biopsy? It was a 3-3 or a 3-4?
It was 3-3.
Okay.
Gleason 6. Yeah. Yeah. But the
No,
real
if you're the guy that worries about it, that's something sounds like you'd worry about. If it was me, I wouldn't worry.
Worry about what?
I wouldn't be thinking that you're in imminent trouble at all.
Yeah. Well, the point is, should I go ahead and get the MRI with Frindle now, or wait and try and go to a live in-bore MRI, because that's what the gold standard would be?
I don't know if that's really true.
Oh, okay. Good.
Yeah, Albert,
Dan?
I think.
Yeah, go ahead, Dan Guilford.
Okay. Yeah, Albert, I think the key thing for you is where is your head at, and what's going to give you the most certainty. And it sounds like you're really kind of leaning toward have an MRI and then have a confirmatory biopsy just to calm your fears. And sometimes that is enough. That's enough reason to have that confirmatory biopsy. Just because Hugh hasn't had one for 4 years, that doesn't mean that you don't need to have one. Everyone's journey is different. Everyone's psychology is different. So you do what's best for you, and don't let our discussion here dissuade you from doing that.
Right.
I think from what I hear from you, you would be more comfortable if you had the MRI, and you don't have to wait for the quote unquote gold standard, although Howard will tell you that's not necessarily the case. Do the MRI, see what comes up with the MRI, and then make the decision based on that.
Yeah.
Do you need to have a confirmatory biopsy or not? And honestly, you're the only one that can make that decision with you and your urologist. But just like we talked about earlier, you need to be well informed, do your own research, and see what's there. And come back. I know you've been here before, but continue to come back. When you get that MRI results, we can talk about it and then see what's best from there. Because you may have more information, or you may have information that says, hey, it's really not that bad. So anyway.
So Dan, you had your hand up.
Yeah, I think you actually said it best, Hugh. A confirmatory biopsy is to confirm the original status. If you've got a new lesion in MRI, we're not confirming anymore. We got to find out what that is, and is it behaving the same as your original lesion? I think one of the things that surprised me about this whole active surveillance thing is we all get so focused on our original diagnosis, but we forget that whatever it is about us, our bodies, and our lifestyle that made us get one cancer, we can certainly get a second cancer in your prostate gland, which is why, as was already said tonight, everybody has to be religious about their diet and their exercise patterns. So I'm thinking if you've got a new lesion, whether you're a worrywart or not, it sounds like they got to find out what that's all about. And this idea of having an in the bore biopsy, that just put that out of your mind. That that's got to be a research thing they're doing at Harvard. And unless you want to go there, you're not going to find somebody else who's going to do that. I can tell you. Just make sure they get a fusion image, that they fuse the biopsy equipment with the image from the MRI, and go ahead and get it taken care of.
Yeah, and I hear Frindle is extremely good at this, so I'm very comfortable with him for doing diffusion, transperineal. So thank you for that advice. I think that's good, and I would feel more comfortable just going ahead with this instead of chasing around after some live in-bore thing. So thank you,
Very
guys.
good.
Yeah,
you betcha. BJ.
Hi, guys. I wanted to quickly share what I discussed with Dan this morning. I had gone to I was told by a good friend for a while to go to a oncologist that he knew for a long time. So I did that, and he sort of like shook up my, how should I put it, active surveillance fantasies, if you will. So here's my situation really quick. I was diagnosed in June 2024. PSA was 5.7. I have done a biopsy. Excuse me, I was diagnosed in April, but did a biopsy in June of 2024 at Cedars-Sinai. I did a decipher. It's 0.36. My
What was your
size.
biopsy? What was your biopsy? The cord.
Oh, sorry. The biopsy was, and just, you know, I'm bad at this stuff, but tell me what
How many
left
cores?
base and left MID. That's what I don't know. If people keep saying cores, I don't know how to read cores. But here it goes based on left base, left MID, left apex, right base. Do these mean core? What the hell do these mean?
Individual samples or cores.
Okay, so it's 1, 2, 3, 4, 5, 6, 7 cores. Okay, and out of 7 cores, they came out with 3+3 on 5, and on 2 of them 3+4. And the confirmatory, the confirmatory biopsy with Dr. Zhao showed that one of them was out of the 2 3+4, he shows only 1 3+4.
Okay, so he downgraded the 7, 8.
On one of them, that's correct. On one.
Okay, that's
all right,
good.
So the other thing is that my PSA free that Dan told me back in 2024 was 4.3. Is that what the designation is for free PSA free or no?
I don't know the.
Is that a percentage?
Anyway,
Does it say percent?
PSA free. It says PSA free 524, and then it says 4.3. And then it says free-16. Does that mean anything to anybody?
Doesn't to me.
Anyway, so let's move on from that. My PSA density, it's 0.05. I've had 2 MRIs. Last one was in May of 2025. And I don't really know what the results were. I'm not sure if they confirmed things, if they said things improved or whatever. Anyway, so fast forward to this guy last week. He told me that in every one of the cores that they have done for my biopsy, it says that perineural invasion is identified. And he believes that shows that my cancer is like, what's the word? It's invading into the nerves. That's one reason he thinks I'm high risk. Number 2.
Dan or BJ, did you say Zhao did your second opinion?
That's correct. Yes.
Okay. Then I would call him back. I would call him back on that immediately.
Yeah, I should do that. So the other reason he says I'm high risk is the 3+4. He says that he looked at all my stuff and he said that I'm 3+4 group 2, and he thinks that that's high risk to begin with. And the other thing is that I did PET scan, which came negative, but he says that that doesn't show very, very little cancer coming out of the prostate to other places. So he's recommending that I do another PET scan, do another MRI. He did another genetic test that I forget what it is. He said the test is going to be there in a couple of weeks. And then he's recommending that I go to a radiology urologist. What do you call it? Radiology urologist?
Yeah.
Because he doesn't.
Rick's got his hand up here. Rick, you want to jump in?
Go ahead.
So just tell us a little bit about who this doctor is that's spouting
His
off.
name, he has a cancer center, which is a kind of a fancy house in the city out here called Calabasas.
Right, I
He
know where Calabasas is. What type of doctor is he? Is he a medical
he
oncologist? Is he a
he is
urologist? Is he a
he's
radiation
a
oncologist?
urology oncologist. He was trained under some famous dude, he said, out of Beverly Hills, who was very, very famous. And he says the same guy trained Dr. Mark Schultz. So he was
Okay.
he said that
I wouldn't put. It sounds to me like this guy is. I don't want to say he's a quack, but it sounds to me like he's a quack. I mean, he's talking through his hat, BJ. First of all, there's loads of evidence that there's no association with perineural invasion spreading. There is association that there's more perineural invasion in higher grade cancers. So if you've got a 4+4 or a 4+3, you're more likely to see perineural invasion, but it's not associated with there's no causal relationship. So that's the first thing. I had perineural invasion. It just doesn't mean it. 3+4 is 3+4. This guy suddenly defined that 3+4 isn't really grade group 2, it's really grade group 3. Where's he getting that from? You know, I mean, you can't make this stuff up. And he, he's looking for you to treat him, get rid of him, and go to a decent doctor. You hear it here all the time. It drives me nuts when people.
well, my decent doctor has already delayed me 3 times, Rick, because he
Okay,
can't
well,
get his
then we'll find
license
you.
together.
Then we'll find you another one. Go
That's
see
Dr. Scott.
as we said to you the other day. Oh, hold on, Howard. Who's that? Who's the other guy, Howard, at UCLA that we like? Well,
Dr. Brisbane or
yeah,
Dr.
Brisbane. Go and see Wayne
Yeah.
Brisbane. Go and see
Yeah.
Issa, what's her name? The lady, the African American, Issa Galloway. Just because you can't get in to see Agarwal doesn't mean you go see some quack who's talking bullshit. You know? And this is recorded. It's rubbish what he's telling you, and you come back here and you tell us. No. And if
I'm sharing it with you guys.
Well, yes, but
get a hold of Zhao immediately.
Oh, wait a minute. What are we getting hold of Zhao for, Hugh?
To ask him about the perineal invasion.
No, you don't need Zhao. Hugh, you don't need Zhao to talk about the perineal invasion.
Okay.
This has been around for years. Go ask Logothetis, and he'll tell you it's not there. Yes, if he had IDCP, they suddenly found it. If he had cribriform, that's fine. But no, we don't. We have to respect these doctors. We can't just be calling them up for anything. And perineural invasion is not something that we need to take seriously. There is enough evidence. It's been around for years. The problem is that when a doctor like this guy tells it to a patient like BJ who doesn't have the knowledge and cannot be discerning, it's a disservice. If you want to give him my number, I'll give him all the research. But don't be saying that. It's just wrong.
Well, again, I shared what I was told. So one question Dan and I talked about this morning. Anybody has done PSMA, PET scan, MRI?
Yeah, and again, you don't need a PSMA PET scan, MRI. You know, I mean, it's like...
You don't think so, Rick?
No, because your numbers aren't there to justify it. You don't have a lot of cancer. We don't see cancer that's necessarily, unless all of a sudden we think that the cancer got out through the nerve channels and it's all over your body. But then you'd be a famous case, and we'll be able to quote you everywhere and everywhere. No. Somebody else said early on, I think Jim Boland, do I need a PSMA? PSMA was developed for other reasons. The fact is, it's out there, it's available. And just because it's out there doesn't mean we all need to get it. Some of us need to get it. And some of us with more advanced cancer, and some of the guys in the high risk group, they definitely need it. And maybe some of those guys who are in grade group 3 may need it. But in my view, you don't need, if you're a grade group 1, grade group 2 guy, unless you're like Greg B, whose cancer is pushing right up against the wall and it's growing, and we've watched it push up against the wall for the last year. Yeah, maybe there's a reason for him to get a PSMA scan. By and large, no. Just because you've heard of it doesn't mean it's right for you. But the doctors, if you say to them, they'll tell you because they make more money off of it.
No, what I was going to do is to get an MRI anyways, but I thought that maybe I'll just get this particular one, just to feel better about this. But I guess I'm gonna have to go ahead.
I don't think you need. I think you need to get yourself with a solid doctor. Make an appointment with Brisbane. Make an appointment with Garraway. And if those don't work, we'll come up with some USC docs for you, with some SC docs for you. But that's what you need, BJ. You don't need these guys who have their own special practices for this, that, and the other, and who knows what.
Hey, Rick, this is Dan. Maybe we can do a little educating here, because this PSMA thing keeps coming up. So the PSMA is a relative but slightly different target than the PSA, and it's really used with a PET scan, not an MRI scan. It's really used with a PET scan, which is a way to find out if your prostate cancer has escaped the prostate and is in somewhere else. So if you showed up in the doctor's office and told them you had prostate cancer and you've been having some back pain or hip pain or something that they couldn't explain, that would be a good time to get it. Just having this guy tell you you should get another PSMA, I mean, it seems like a waste of your time and money.
Yeah.
Let me just clarify something for Howard. BJ's been trying to get an appointment with Egner. That's who he's referring to. And Egner hasn't got his license to practice in California yet. So it's frustrating BJ because he can't get to Egner. We could get him in to see Egner, but Egner's not seeing any patients right now because he doesn't have his license. He's waiting on it. That's the problem, Howard. As far as the PSMA scan is concerned, thank you, Dr. Dan. Yes, you're absolutely right. One thing that you need to know is that PSMA is a protein that's expressed on a prostate cell, and that it doesn't usually express itself unless you have fairly aggressive cancer or fairly advanced cancer. So a normal healthy PSA cell, a prostate cell, is not going to express PSMA, but a more aggressive cell is going to express PSMA, and it's not a great tool to use for looking inside the prostate. It's really used to look outside the prostate where we don't normally see prostate cells, because it's going to show you. It's also going to show you some other cells in other parts of the body that make PSMA but are not in the prostate, even though we call it prostate-specific membrane antigen. So it can be quite confusing, but it's not the ideal tool to identify prostate cancer inside the prostate.
Howard, any comments you have?
What Rick said. Yeah, it sounds like you're being, I mean, if you talk to the typical patient and you talk about perineural invasion, it sounds like America going after Venezuela. It just sounds scary. It sounds scary, and it sounds like nerves. But like Rick had said, if there's an association with cribriform, for example, which is a specific pattern that looks like Swiss cheese, it's got holes in it, that's something to be worried about. But if nobody told you you have cribriform, that reduces the issue. I don't know much about intraductal cancer, but I'm on board with Rick. But you shouldn't be embarrassed about what somebody else told you. You should just kind of look into it, and you need somebody at UCLA, for example. So I know people who see Brisbane there, and they're very positive about him. I don't know how hard it is to get in.
Yeah, they're backed up till January or something, but that's not too far out.
Yeah, that's not too bad. You just got to be patient and don't get scared by paraneural, the invasion of the paraneurals.
Yeah, you're no worse off tonight than you were this morning, BJ. Here's what I would really encourage you to do. Feel free to send me or one of these guys a note anytime about a doctor you want to see, especially if it's somebody sort of out of the ordinary. Run it past us, and we'll give you some guidance. We can't give you medical advice, but we can give you advice on docs. Which docs to see. We're allowed to do that.
Okay, I appreciate that.
I'm happy to do it. Really with absolute pleasure. We're very happy to do it. Because what we don't want to see is what's happened to you today, which is it creates all this anxiety, and that's not good. And your situation, you're in the sweet spot to watch it. You don't have a heck of a lot of cancer, and PSA isn't really going anywhere. And we don't want to wind up that anxiety level, which is what happened to you.
Okay, thank you so much. Yeah, I will.
Because we love you, BJ.
I will take this with a grain of salt. And today I was a little down, but I went up and had a cup
That's
of
why you come here.
decaf latte and walked my dog, and it was beautiful sunshine in Southern California. So I'm happy.
Okay, but
Thank
get
you,
your
guys.
ass over
Appreciate
to
it.
Brisbane or to Isla
Yes,
Galloway.
I almost made an appointment with him, but I'll call tomorrow for sure. Thank you.
Okay.
Okay, so does anybody want to tell BJ how bad the what did you say, the latte and everything that you had? You really shouldn't have that. And
extra hot.
That's
it was extra hot with almond milk, and it was decaf.
That's terrible for you. I'm sure there's a study that shows that that's terrible for you.
BJ, put the caffeine in it. You'll feel even better.
Yeah.
There you go.
And
guys,
there's lots of studies actually recently showing that caffeine is actually pretty positive, especially if you have AFib. So, in the past, people who had AFib stayed away from coffee. This is not true. There's now a study came out from UCSF recently saying no. So there's lots of good things about caffeine.
Rick, go back and find that study that says that, several glasses of red wine is good. Okay, now you
the resveratrol. Howard will find you the resveratrol study. I bet Howard knows where that.
I think that's trending the other way, Hugh.
I know it is. That's why I want you to trend it back. Well, guys, we're over the limit here. Do we have anything else? We got to kind of rippity do here. So if there's nothing else pressing, I call for adjournment, and we'll see you guys next week. And I'm going to turn off our recording. Thanks, guys.
Okay.
Hugh. Thank you, everybody. Good night.